I'm just going to introduce them briefly as soon as I find my notes. There they are. So Dr. Jen Stinson is a nurse clinician scientist in the Child Health Evaluation Sciences, a nurse practitioner in the chronic pain program at Hospital for Sick Children, and the co-director of the Sick Kids Center for Pain Management, Research, and Education. Her major clinical research interests are in pain and symptom management, the use of e-health and m-health, technologies to improve the assessment and management of pain and other symptoms in children with chronic illnesses. Laura Malone is a pediatric neurologist and physician scientist at the Kennedy Krieger Institute. She's also an assistant professor of neurology and physical medicine and rehab at Johns Hopkins, and she is the co-director of the Pediatric Post-COVID Rehabilitation Clinic and contributed to national programs and guidance regarding pediatric long COVID. She is one of the leads for the pediatric work group for the Rehab Society's long COVID and post-acute sequelae of COVID Quality Improvement Collaborative, and served on the planning committee for the long COVID and disability workshop organized by the National Academies of Science. Deirdre Logan is Director of Psychology Services and Division of Pain Medicine and Department of Anesthesiology, et cetera, at Boston Children's, and Associate Professor of Psychology at Harvard Medical School. Deirdre received her PhD in psychology at University of Michigan and her postdoctoral training at Children's in Philadelphia, and then was faculty there till she went to Boston. She's led the pain psychology program at Boston since 2007. Deirdre's research focused on psychological aspects of pediatric chronic pain with an emphasis on roles of school and family systems in the child pain experience. And then finally, Dr. Kara Hoffert is an associate professor of pediatrics in the Division of Rheumatology at Children's Mercy in Kansas City, in affiliation with the University of Missouri, Kansas City, and the University of Kansas Medical School. She's had a long interest in treating chronic pain, specifically pediatric juvenile fibromyalgia and other central sensitization syndromes. She did her peds rheumatology training at Children's Philadelphia and has been at Children's Mercy since 2012, where she's medical director of their intensive rehab program, as well as the chronic pain management clinic. So those are our four speakers. And what we're going to do is I'm going to ask each of them to speak for 5 or 6 minutes about what their particular topic, and then we will open it up for conversation, questions, and further discussion. And I will play Oprah and coordinate all that discussion, hopefully. So take it away, Jen.
Just have to unmute myself. Thanks, Bill. So I want to talk about the work we've been doing in Canada. So it's not specifically just at Sick Kids, but for the development of a step care portal for young people with chronic pain. So again, I've been doing this in collaboration with my two co-PIs, so Dr. Melanie Knoll and Dr. Katie Burney at the University of Calgary. So we were funded by CIHR early on in COVID to look at the impact of chronic pain on young people and the healthcare system. So we did a couple of surveys. We surveyed the clinical directors of all the 11 clinics in Canada. And then we also did a nationwide survey of just under 700 young people with chronic pain, parents, and siblings. And then we conducted some knowledge synthesis and scoping reviews to then use all this information to co-design an intervention that would be freely available using a step care approach for young people with chronic pain. And I'm just going to touch quickly on some of the high-level responses. So basically, everyone halted clinical care during the early parts of the pandemic. Some institutions like Sick Kids, we were able to pivot within, 72 hours to get most of our patients after March 13th seen virtually. A lot of people in the community had stopped providing practices in terms of physical therapy and psychological, and all of them reported technological and financial and infrastructural barriers, privacy concerns to providing virtual care to young people during the pandemic. Then for the interviews that we did with some of the qualitative interviews with healthcare professionals, so we interviewed child life specialists, psychologists, nurses, and all of them talked about the dual impact of COVID on the pandemic. So exacerbating existing mental health concerns, stress, exacerbating existing inequalities in socioeconomic and access to care, and that some people actually did better during the pandemic and other youth did worse. And then also noting the impact of the changes on the healthcare system, being able to triage patients, getting them access to the services they need, and then how they shifted to virtual care and some of the benefits actually of that, and that most of them said that they're going to continue providing care using a hybrid model moving forward. We then, as I mentioned, surveyed youth, parents, and siblings. And again, you can see a range of impact on pain and mental health. So worsening pain symptoms, worse pain interference, anxiety, depression, major depression, and increased drug and alcohol use. And this is similar to national evaluations that have been done looking at drug use in young people during the pandemic. And then we did see an increase in young people seeing their healthcare provider or going to the emergency room for pain, largely because they couldn't get access to supports in the community. We then did interviews with some of those youth, parents, and siblings. And again, talking a lot about how they had to adapt to the pandemic, related specifically to some of their self-management strategies and changes with interpersonal and social sacrifices in terms of loss of friendship and personal interaction. And then obviously what I talked about before in terms of the challenges of accessing healthcare. This was led by Katie Burney. She did a knowledge synthesis of looking at best practices for virtual care for young people. And these are freely available on her website. Again, talking about how we need to leverage and access care, how we can improve, and then what are some of the still gaps that we don't know in terms of virtual care practices. We then brought together a diverse group of youth from all across Canada. We put out a call and we had 54 people apply, and we had 8 youth that were in our advisory group, and they helped to co-develop what we've called now the Power Over Pain portal. And we've done usability testing of that. And I'll just show you a couple of screenshots. The purpose of this is to really provide freely available step care solutions to young people. So they basically can access this 24/7. They just have to register and create an account and give some minor information like what province they are from, because some of the resources are provincially led. And then basically they'll have access to self-assessments. So looking at anxiety, mood, sleep. And based on those scores, there'll be pushed interventions that we know are evidence-based. So you can see here Tanya Palermo's web map, the program we've developed at Sick Kids, which is an I Can Cope app for young people, Bill's evidence-based yoga programs. And then we've just received funding from CIHR to do 2 evaluations. One is recruiting young people in the community who are not seen by pain services, looking at implementation and clinical outcomes. And then we also have funding from CIHR to target young people that are on the wait list, because we do know during the pandemic that the wait lists in all the chronic pain clinics in Canada have doubled or tripled. So we're trying to be able to provide services to young people waiting for care as well. And then just to wrap up, that obviously during the pandemic, it's really needed us to focus more on high quality virtual care to not only prevent pain, but also reduce the mental health toll that it's having on young people and their families. And that we think this Power Over Pain portal, which is using step care, can help improve the accessibility and reduce some of the inequities that we've seen in healthcare that the pandemic has heightened even more. And then just acknowledging all the collaborators in Canada who are part of this program. I'll just stop sharing.
Thanks, Jen. That's great work. So we'll have time to discuss and ask questions, but next we're going to turn to Deirdre Logan. And Deirdre, the floor is yours.
Thank you. So that is an amazing contribution. I'm going to shift the focus a little bit. and talk for a few minutes about how we at Boston Children's have tried to create services for kids who are presenting with post-acute sequelae of COVID, PASC, also known as long COVID. And I think we'll hear from some of the other folks about how those kids have been handled in their institutions, and hopefully from some of the rest of you as well. So I think many of us are seeing these kids now showing up at our hospitals with longer term effects that are developing after an infection with COVID-19. And because this is such a new group of kids, I think we're all trying to feel our way along in terms of what we can do for this group. In our hospital, these kids often come in through the infectious disease clinic. So they have kind of been the first line of entry into the hospital. And as those clinicians have seen more and more of these kids, they have reached out to several of the rest of us to try to pull together a team. So as you all know, kids with long COVID present with sometimes with cardiac issues, sometimes with pulmonary issues, sometimes with pain, lots of times also with kind of a cognitive fog sort of picture. And so we've kind of brought together a group which includes not only the infectious disease clinicians, but representatives from cardiology, from pulmonary, from neuroimmunology, and then those of us in our pain clinic. And many of the kids who come in complain of some grouping of those symptoms, and then they are sent out to the rest of us to all do our pieces. It's been a challenge because, of course, this came along when all of us had full-time jobs already and lots of other patients that we were trying to care for. And now we're in this position of trying to pull all of these busy clinicians together and come up with a unified approach to seeing these kids, and come up with, questions that we need to understand about them and a game plan. So it's really been a first experience for me of kind of figuring out really from the very beginning, what does this group of kids need and how can we do it? We're trying to move toward, I think, a better way of doing that, in that we are trying to create more of a multidisciplinary pain experience, or clinic experience. We would like these kids to come in and actually see most of us all in one visit, the way we do in pain clinic, rather than come in and get referred and referred and referred. And so that's a challenge, is, by the time they get through all of those people, it's now 3 months later at best, and then we have to come back together. So we are trying to move toward a system where maybe we get more information up front about which symptoms are troubling these kids, what's going on, and then create an experience where they can come in and see a group of clinicians who can address some of those things. I would argue, and I'd love to hear from others as well, that pain clinic plays a particularly important role, really for a number of reasons. Number one, many of the kids do have some type of chronic pain, lots of headaches, lots of joint pain, kind of diffuse pain complaints. So treating pain itself is an important piece of treating these kids and families. They also, many of them understandably, have a lot of psychological distress. And right now, among those clinicians that have been pulled in, our group is really the only group that has psychology as part of it. So we are right now sort of trying to address all of the psychology for these kids. We are kind of dreaming of maybe more of a COVID psychologist someday who can take a different view and also doesn't have a whole other population of patients to be treating. But right now we are that mental health piece. And so really thinking about all of those issues and how we can help with that. And then we are also the group that really has a kind of functional rehab framework. And that, I would argue, is a lot of times what these kids need. First, they need someone to kind of look at the serious, scary stuff and let them know, hopefully, that those pieces are okay. And if that is the case, then help them move along into more of a rehab approach and say, okay, so I've got these uncomfortable symptoms, I've got this distress, how am I going to get back to doing all my things? And working with them and bringing in resources such as physical therapy and cognitive behavioral therapy, and trying to get them on that kind of functional pathway. So that's what we're aiming toward. One challenge we've had, another challenge we've had along with some of that scheduling stuff, is sometimes these folks get a little skittish about the idea of a pain clinic. So, the infectious disease person will say, okay, now I want you to go see pain clinic. And these are families that's not been something they've been thinking about. And so they kind of freak out. So we are also working on kind of the language around that. How do we explain what it is that we offer and why that's an important piece and why they could benefit from that? So the framing of that and getting all the clinicians to kind of have their language about talking about that is another piece of this. And then finally, the other thing I wanted to mention is that at the same time as we're trying to embrace this group clinically and figure out what they need and how we can create it within our system, we also want to understand this better, and why do some of these kids develop this past presentation after COVID? We have some theories that they look a lot like other kids we see in pain clinic who maybe had some other viral process, and it kicks off, more of a centralized pain experience for a subset of kids, and that there may be some underlying risk factors there. So we've also tried to put together a study looking at kids who are diagnosed with COVID across our system, some of whom do develop post-acute COVID symptoms and some of whom have COVID and recover, and try to get some questionnaire self-report data from that larger sample in order to see if we can identify any patterns of risk factors and protective factors that may be at play. So if we can, for instance, find, early developmental history that may be more elevated in kids who go on to develop this, or a particular psychological profile or a set of psychological experiences that may make kids more at risk. Hopefully by understanding some of that, we can keep an eye on that going forward and jump in and try to address things more quickly and hopefully get folks back on the right track as quickly as possible. Another big challenge in all of this institutionally, I think, is that no one knows how much work in this line is ahead of us. So, we've put all these people together, we've been asking for these resources and designating ourselves as, a hospital center to get some support. And we don't know, is there going to continue to be a huge influx of these patients, or are they going to go away and we aren't going to need to do this anymore? So that's another real challenge, I think, at more of an institutional level, is just figuring out the long-term plan here, because it keeps changing on us. But that's what I've got, a little bit about what we've been doing, both clinically and clinical research wise here.
Thanks, Deirdre. That was really interesting and helpful. Next, Laura, could you tell us about what's going on at Hopkins in your program?
Sure. So thanks for having me here today. So as was mentioned, my name is Laura Malone. Our post-COVID clinic is at the Kennedy Krieger Institute, and we have a multidisciplinary rehab-based approach, which sort of ties in nicely to what Deirdre was just talking about. So our model, so we created the clinic very early on in the pandemic, but didn't get a whole lot of patients for sort of that first summer, because long COVID in pediatrics took a while to, I think, be recognized. But we have had an influx of patients and have had to expand multiple times, which I think gets to a little bit of the organizational difficulties in navigation and things like that. But our model is that we have patients come in and we have multiple different providers see them all throughout the morning. So the clinic is made up of pediatric neurology, which is myself, and then we have a rehab physician that helps co-direct the clinic with me. And in our clinic, we have behavioral psychology, we have social work, we have physical therapy, and then we have expedited referrals for patients to be seen within about a week or two with a couple neuropsychologists that have designed a specific battery for complaints of brain fog or difficulty with school. And then we also have a school educator that we've added to our clinic as well to help with the education piece. And then similar to a lot of other models, we can't have every provider in clinic all at the same time, just due to time limitations. So then we've identified subspecialists that sort of see our patients in other specialties, pulmonology, GI, various different specialties with that as well. As Deirdre was mentioning, I think that pain is a very common complaint. As a pediatric neurologist, I am managing a lot of headaches in patients, and it's very, there's pain from lots of different sources. And so trying to tease apart sort of what is the most debilitating symptoms and how to approach it, I think can be complicated. And so that's our approach is to sort of improve functioning regardless of the exact underlying etiology. And so we refer and sort of do diagnostic testing to rule out other treatments that might be appropriate in other diagnoses, but then really focus on functioning and sort of take it all as sort of a whole in order to try and move the patients forward, which does include a lot of pain treatment as well. So that is sort of our model. We've grown, we've learned a lot as time has gone on, and just continue to still try and learn more. I think one of the things that we find a lot is that we're very upfront about it being a rehab-based approach. We don't have a magic pill or medicine to treat this, and it's very individualized approach to care. But you know, a lot of patients and families want to know why exactly this is happening, and you know, what can I do to either prevent it or cure it? And we don't have the answers to that. So I think trying to work with research in order to understand that better. But for now, we sort of really focus on symptomatic management, which we do find really helps a lot of our patients. So we can give them hope with that type of information as well. So I will leave it there, and then happy to answer any questions during the panel discussion.
Great, thanks, Laura. And then finally, Kara.
Hi there, I'm Kara Hoffert, and I'm a rheumatologist at Children's Mercy in Kansas City. I appreciate being invited to participate today. And while I wanted to share what we're doing, I also am very interested in hearing what everyone else is doing. And I echo a lot of what Deidre and Laura already shared as well. So we have not developed a specific COVID clinic at this point, partly because we see the patterns of these kids being so similar to the other patients that we do see. And as Jen pointed out, lack of resources as a whole, and being able, and all of the interesting barriers and hoops that Deidre was pointing out. And we already, and as I'm sure many here do, already have a lot of close ties with other groups, such as our complex syncope clinic, our headache clinic, our abdominal pain clinic. And so we already have some fast track ways to get patients where they need to be. And as a whole, we found our pain management clinic continues to be the place with the greatest infrastructure, also that functional approach, as well as psychological services that many of the other clinics don't necessarily have. Interestingly, I think a fair number of these patients start out being seen in rheumatology clinic for joint pain, of course, and then the ever-present fear of some type of an autoimmune disease or something else that's being missed related to an inflammatory condition, especially after COVID. So our infectious disease folks don't actually see these kids in follow-up unless they're continuing to have fevers. And I think they end up landing on our doorstep in rheumatology. And then the kids that aren't getting better in that clinic get funneled over into our pain management clinic. I think we expected a much larger influx than we've seen. We certainly see these patients, but looking at what the adult prevalence seems to be, with anywhere from 3 to 30% of people who are infected with COVID developing long COVID symptoms, we have not necessarily seen that type of volume. We've done some shared studies with our pulmonology group. They looked at the first half of the pandemic and they had about 20 kids with post-COVID continued cough or dyspnea. And the majority of those ended up being more concerning for anxiety-related dyspnea or other types of functional issues with vocal cord dysfunction and those types of things. And they really were being referred on to speech therapy, physical therapy, and psychology for the most part. Our friends in complex syncope clinic, since we overlap with them quite a bit in our clinics, they have found that they are able to still treat these patients similarly that they treat other patients who have orthostatic tachycardia or POTS, and they've responded similarly. They have found that craniosacral therapy seems to be helpful in this group with some of the work that they've been doing, partly because it's so acute and virally induced. So they have seen improvement with craniosacral therapy as well. And our sleep friends also have not had a huge influx of these patients. Really, most of the work that they're seeing within their group in our hospital, but also more nationally and globally, it looks at the changes in sleep and insomnia related to the pandemic itself and the lockdown, and not so much related directly to infection with COVID. So all of that, I think, is pretty interesting. And as a whole, our messaging has stayed the same as what it is we see with other kids with chronic pain conditions, which I think is really important. And I think in pediatrics, we do a nice job of really continue to work on that functional messaging and hope for improvement. It's kind of interesting to watch what's evolving in the adult world. And so I think making sure that our messaging within pediatrics remains this idea of functionality and I think hope for improvement. And so certainly we're addressing these post-COVID kids. I think it will be interesting to see over time how this evolves and how much we are needed in this realm. As I said, I think these kids do look similar to other post-infectious pain conditions, but also just looking across the board as the variants have changed, so have some of the sequelae that we have been seeing. So for example, we treat kids in rheumatology with multi-system inflammatory conditions in kids, and those kids are incredibly sick in the hospital and present as kind of a Kawasaki or shock picture. And with the Alpha and Delta variants, we were seeing probably in our hospital anywhere from 2 to 3 of those kids every week. And then with the emergence of Omicron, we thought, boy, we're going to be in big trouble with the last surge. And really, we were seeing like 1 or 2 a month. And so we're seeing that that is kind of changing over time with the variants, as is things like anosmia. So it'll be curious to see how maybe pain conditions and associated symptoms change over time as well. I think our biggest concern is more with what Jen has brought up, is just the overall influx of pain patients in general. I think as a result of the pandemic, when we first went into lockdown in March of 2020, interestingly, a lot of our patients were doing much better. And I realized that the stress of COVID was less than the stress of school, and things kind of seemed to look up. And then basically that following year, everyone was on virtual schooling, which became stressful. And now everyone's back into school and mitigation efforts decreased. And there's a lot of stress around just COVID mitigation, vaccines, and just being back into full-time school again. And I think our kids have just been yo-yoing back and forth with what's expected of them without the appropriate supports. And so we have seen our pain clinic referrals triple from what it was 3 years ago. And so being able to get these kids seen efficiently and quickly is becoming ever challenging. And one of our greatest barriers is psychological support. And we have great psychologists in our clinic, but it's not enough. So we have actually been thinking outside of the box and are working to recruit some master's level clinical therapists as well to help fill some of those holes. So that's what's happening in our institution.
Kara, that was really helpful. And I think your experience, unfortunately, mirrors a lot of ours. So I have a lot of things that are going around in my head. But first of all, I'd like everybody who's willing to turn their cameras on so we can see all of you. And then I guess my first question for the group at large would be, is anybody doing anything radically different with the post-COVID kids than has already been described by the panelists? Because if you are, I think we'd love to hear about it. If you have any novel approaches or differences, that would be great. And please raise your hand and realize I'm on 2 screens. So if somebody else, if they see a hand raised, let me know. I don't see any hand raises, so I'm assuming that means that nobody is really doing anything radically different, which I guess doesn't surprise me all that much. And it's, I do think it's admirable how a lot of places have rapidly kind of thought about this as a new disorder. And I guess that's where my question is, from all the panelists, and I'd love to hear from the panelists some more, is this different? Clearly there are differences, the MISC, the pulmonary disease, et cetera. But once they get to the pain clinic, are they, or these functional clinics, are they different than any other patients that we're already seeing? Or are these just slightly different, similar approach, similar patients, just another post-viral, if you will, syndrome? Thoughts? Laura?
So I think that given our knowledge now, we don't have any evidence that it's different. But some of that may be that we just don't, understanding the pathophysiology behind long COVID is still very theoretical at this point. I think that there seem to be almost different phenotypes of patients that then you can sort of correlate to other syndromes, the post-viral fatigue syndrome, or some that look more like the dysautonomia with POTS. Younger kids, we're finding sometimes a little more to have what feels to be more like rheumatologic, even though they end up not having true, diagnoses that match that, but more fevers and joint pains type of thing. So I think that it's interesting that the similar virus is causing sort of all these different phenotypes, which me personally tends to lead me to think that there might be something about the host with regards to if there's some sort of immunologic predisposition or immune response that causes all these different sort of phenotypes in the patients. But there may be something different, but I don't know that we really have the evidence at this point to say. Not that I've seen yet, at least. I would love to know that.
Deirdre, from the psychological standpoint, I've noticed, and actually one of our psychologists, Dr. Sandu, and I have discussed this, because we end up seeing a lot of these kids, and it may just be the duration of illness. They don't seem to be as psychologically complex, in my view, as some of the other kids we're seeing. And that may just be a duration of illness. We see these kids fairly quickly because of the pathway by which they get to us. So I don't know if you've noticed, have thoughts about that. What do you think?
I would say there's something to that. One of the things that's interesting is that many of the kids that we are used to seeing, feel so unseen out there. No one else their age has chronic pain. This is such an unheard of thing. And, not that the long COVID is, that different, but COVID has so much of our attention right now that I think it's a different experience in terms of feeling maybe more validated, or, people are paying attention to this, and not necessarily that same kind of I've been dismissed over and over again kind of presentation that we often get by the time other kids get to pain clinics.
Yeah.
Another thing I was thinking about a lot early on that has changed over time is that, in the early part of the pandemic, we were also trying to be really thoughtful about the level of other trauma that a kid who dealt with COVID might have in their family. There could have been older, and there still could be, older family members who had been really sick or even passed away. Now it's, feeling a little different with vaccines. That's not quite as much the picture, but just thinking also about, a kid showing up with COVID, what else has that family been dealing with in the recent piece of things?
Great. Jen, you're in your Power Over Pain app, you have kind of three options. You have your kind of I Can Cope content, Tanya's some of Tanya's content, and my yoga content. So I'm curious, do you have any data on patient preferences, what type of content they're looking for, et cetera?
Yeah, so we based it on a step care model, and I actually didn't show you all the steps. So the first step is basically pain neuroscience. Mm-hmm. So there's some great videos that have been made by Boris and other people, Tame the Beast. So that information is level 1. So everyone should get basic education about chronic pain. The next level is sort of self-management strategies. So that's within Tanya's well-validated WebMap program, our I Can Cope, movement-based therapies, which is the yoga. And then we are in one of our trials adding peer navigation, sort of to get at some of that peer support, but also to help the young people figure out what aspects they should be using. And we've also built a clinical algorithm. So we do assessments every 2 weeks, like a brief, the PROMIS profile. And then based on those assessments, we kind of push interventions to the young people. So if there's some mental health stuff flagging or some sleep issues flagging, we send them to the sleep modules within I Can Cope or WebMap. And we're working with other people to try and get other interventions that are going to be freely available after they've been evaluated, to continually update the portal as new evidence becomes available. And then in Canada, the similar model was developed, it's called Wellness Together Canada, Wellness Together Canada. It was built within 3 weeks of the pandemic to provide mental health support and substance use support, because the government realized that this was going to be long lasting and have an impact. So it's linked to that portal as well. And so in each province, there's dedicated mental health support that if the kids need, they can go there. And then the final step would be referral to one of the 13 tertiary clinics.
Great, thank you. Before I go to our audience, I'm going to ask one more question. This is for Kara, but certainly anybody else can chime in. I wonder, Kara, are there interventions that you've noticed, at least in this specific population, are more helpful than in other pain populations, or maybe you're using more, doing anything different, or is it totally kind of your same approach?
It's been fairly standard. Honestly, I think the reassurance piece of, evaluating to make sure that there's not something else going on from an autoimmune standpoint, and that whole discussion of dangerous, not dangerous, as far as their pain and symptoms goes, is really critical. And we're seeing a lot. I agree. I think there are some different phenotypes in these patients. And so it seems like the dysautonomia piece is pretty significant. So sometimes with that, we'll tend to maybe utilize biofeedback a bit more. But regardless, I think the overall approach with physical therapy, occupational therapy, stress management strategies, et cetera, still remains pretty imperative, and just working on those functional goals is what we're generally seeing. But I agree that different phenotypes are fascinating. And I think in this population in general, I agree. I don't think they're maybe is psychologically entrenched because we are able to catch it a bit earlier. And I'm finding that these kids seem to be improving relatively quickly compared to some of our other patients that come through the normal channels. And many of them are just followed by my rheumatology colleagues, actually, and they don't even make it to our pain clinic because they improve within a visit or so, which has been a bit different.
Great. And, I just want to echo Deirdre's comments about stigma. And, I think hopefully the experience with long COVID is going to destigmatize our chronic pain patients and our chronic fatigue patients by osmosis, perhaps. I think that will be a wonderful outcome. It also will hopefully, given the amount of money and research that's going towards this, help us understand a lot of our patients better, not just the ones who've had COVID. I'm going to Grace Hong, who's actually another member of our Connecticut Children's family. She's a nurse practitioner in infectious disease clinic who was really set up with developing our whole approach to long COVID. And she asked Laura about a screening process for multidisciplinary patients so that we can send them, to the right place and get them the right resources. Laura, can you just talk about what you do at Hopkins? And I'd love to hear from any place else who's screening patients, trying to get them to the right resources. At Connecticut Children's, we have an entry point through ID. But Laura, just tell us a little bit about your process, and then we can go from there.
Sure. So the way that it works right now is that parents or patients can self-refer PCPs or other specialists that just hear about the clinic. And then at Kennedy, any new patients goes through a standard intake process, just getting medication history, developmental history, and then like the reason for the visit and things. So once they go through that, there's just a brief paragraph about the symptoms and the reason that the patients are coming to see our clinic that my co-director and I review and just sort of make sure that it's appropriate. If we feel like they would be better served in another clinic that we have here, we'll divert them. Otherwise, if there's anything that we feel like it might need to be more urgent referrals, whether that's cardiology or pulmonology, rather than waiting for us to be seen, we'll go ahead and reach out to the family to say, in the meantime, we think this would be helpful based on your symptoms. So right now it's sort of our review of the cases. And that's what we've been doing so far. Obviously, if clinic continues to expand, there might need to be a more formalized approach and things with that. But yeah, it's just sort of an evaluation of the needs and if we think it would be appropriate.
Deirdre, you said your patients come through ID. Do they do any specific screening to decide where to send patients next?
So we are refining that these days. We're trying to use our same patient self-report platform that we use in Pain Clinic. We've now gotten the ID folks on board with that idea. And actually Natalie Benjamin, who's a psychology fellow with us, has been kind of championing that effort to kind of create a survey that ID can use to get information up front about the different symptoms, and then hopefully plan who else will see the patient so that it's a little faster. One of the things the Pain Clinic struggles with in trying to figure out the best timing of that process is that we like to be the people who can look at all the other evaluations and kind of rule out the danger piece and then say definitively, we can put aside those worries and we can really focus on functioning. And so the timing of the other visits kind of matters because we want to sort of be there after they've seen these other folks and after we can kind of stop worrying about some of those things so we can frame our message accordingly. So that's tricky. We've had patients call our clinic and sort of trying to tell them, like, you know, go call some other people and then call us back again. It's hard to figure out how to deliver that message nicely.
Is anybody else on the Zoom? Please, if you're from another institution that's might tell us what you're doing at your place. Love to hear from you. Anyone? Bueller? Anyone? No? Okay. So Jen had a question about registries. Is anybody developing a registry for pediatric patients? I will tell you, for those who don't know, in the US, there's an effort, a large NIH study called Recover that is trying to, it's not a registry, it's trying to look at 20,000 kids, well, more adults, I don't know exactly how many adults, but about 20,000 kids who've had COVID, and then tease out, you know, those who've had long COVID and do in-depth studies, you know, blood studies, imaging, et cetera, on those. We're actually a site, but for reasons that I won't get into, we have not started enrolling as of yet. It's a fair source of frustration for me. But anyway, other people developing registries or ways of looking at these patients?
I will say that's the other hope of our upfront patient report measures is that not only will they inform the plan clinically, but then also we'll be collecting this information on this post-COVID group and we'll be able to hopefully catch some patterns.
Yeah, we're trying to build just a local registry here of our patients. The other, so the APMNR, who has a long COVID quality improvement initiative, is working on developing things like epic smart phrases and sort of core outcome measures. And they're trying to figure out how to do that systematically in order to do multi-institutional sort of tracking of patients. I think the complexity exists sometimes because there's so many symptoms sometimes, and thinking about just the time that it takes to collect all that data and information has been practically limiting. But there's people that are trying to work on that on even more national organization.
I wonder, you know, that we have I've been talking to somebody who does something called phenopackets, where he is able through download and develop, you know, to access directly from Epic information in the medical record, where he can divide patients up into phenotypes using medical record data. That might be something as a group we could talk about, because they need a fairly large number of patients to do something like that. But that might be an interesting study to look at, just to even see if there are different phenotypes within our populations. I will note in ours, the degree of orthostatic intolerance seems to be much greater in these patients than in some of the other kids that I've seen so far. But, you know, we'll see where that goes. Was there another?
I was just going to make a comment. I did post in the chat that there is an international organization that has come up with a core set of outcome measures for adults with COVID. But to my knowledge, there's nothing been done in pediatrics, but it might be a good starting place for people that are interested in that to look at those. They're freely downloadable from that site.
Great, thanks. Neil asks, are there differences in the post-COVID demographics, i.e. Our typical pain patients are mostly female and teenagers? Thoughts from anybody, either on the panel or not on the panel? I'd love to hear from some non-panel folks. I see you all there. Please speak up and let us know what's going on at your place. I'll give you a cookie. All right,
Hi there.
anybody?
I can jump in, Bill. So I'm Claire Reed. I'm one of Bill's colleagues, and I'll say that among my patients, I've had many skewing younger, actually, between the ages of 8 and 12 more so, as well as more diverse in terms of racial background. So I don't know if others have had that similar experience, but it does seem to include a more diverse subset of patients.
And Claire gets a piece of leftover birthday cake for that, because there's some from yesterday. So other folks, anybody on the panel want to chime in on that question? Kara, what are you seeing?
Yeah, I would echo. I've seen some younger kids, so our typical teens as well, but definitely those younger kids, 8, 9, 10. We've seen quite a few of those as well, especially in the younger kids, and a more even split we've seen between male and female is what we've seen.
Great, thank you. Paula asks a question. I'm wondering how they're doing socially, and I think Paula broadened out her question, not just talking about kids with long COVID, but our pain kids in general. How has the pandemic impacted their social experience, their social growth, et cetera? Jen, you want to comment on that?
Yeah, well, they definitely talked about the social restrictions impacting them. And some kids that are sort of have fear of social interactions were doing okay, but then those kids, there's some kids that just thrive on social interactions, right? And they were really restricted. So they were talking about the impact of that. And I do think in the adult measures, they have loneliness as a concept that they're measuring for COVID. And I know, Paula, you're doing work in this area now, funded by CIHR. I don't know if you want to mention the project you're doing, but
yeah. Well, it's just, yeah, I was just wondering how they were actually doing, because I wonder if, you know, they've been separated more and they were already struggling on how to interact with people, and then they've been home and isolated. Are you finding that they're just not coming around, that they're even worse than previously? So yeah, Jen and I actually are doing some work on loneliness and COVID. And so looking at the types of loneliness that they may have had pre and post COVID, and how COVID has affected them. But yeah, I'm just wondering how they are socially doing, especially, you know, these little ones, because we're used to dealing with teens whose, you know, social interaction challenges may be different than younger kids. And so I was really concerned when I heard that your patient populations are maybe even, you know, demographically younger than what we're used to seeing.
Well, you know, it's interesting, Paul. This is not entirely related, but last weekend I was away with some friends, and one of them is a first grade teacher. And she said the degree, just for these normal kids, of social, you know, retardation, if you will, and you know, all educational struggles as well, but even more just the social piece of how, you know, that's what they learn in kindergarten, right? You learn that, and these kids didn't have that experience. And you know, it'll be interesting for us in 10 years when these kids are all adolescents, vis-a-vis the trauma of this whole experience and the developmental challenges, how that impacts long-term outcomes for these kids in a number of realms. My developmental pediatric mentor, Dr. Schechter, might want to comment on this. He'll be so proud of me that I brought this up.
I'm extremely proud of your conversion from an ER doc to what he thinks more broadly, but above and beyond that, yeah, I agree. There's so many developmental differences here that are occurring, or changes, that it's really going to be hard to know. I think it depends on the critical times too, whether there are actually critical times or whether it's all a continuum. A lot of individual differences. So I think it's going to play out, as Jen was suggesting, very differently. And and people of different ages with different temperaments. But clearly, it's going to have a dramatic impact on the next generation of kids as we see, and we really need to be alert to that and deal with it, because we were dealing with a lot of anxiety prior to this, I think, and in our populations more than we had seen previously over time, and I think this is going to dramatically add to that.
And even regionally, I think there's so many layers to this. Like, you know, how long did kindergartners and first graders go without being able to see whether anyone was smiling at them because their part of the country was keeping masks on forever and other kids weren't? And how long were their activities all canceled? It's such a mess. There's gonna be so much multi-level modeling that we're gonna have to do to understand any of it.
Other questions from the group? We'd love to hear, we have a few more minutes. I'd love to hear any more questions from anybody out there, either through chat or in person.
I do have a question, just talking about the long COVID patient population. My name's Kim Harris Eaton, and I do work with Bill also. And the patient population that we're working with, returning to school, the patients were staying at home. They were thriving at home in school and doing pretty well, but then going back to school was a struggle. So that's another big struggle, trying to get kids back into the school environment post-COVID. So I was just wondering, are you all across the country having the same experiences? And yes, Bill was talking about cake, but did he talk about his good and plenty experience?
Lots of good and plenty gifts as well yesterday. Thank you, Kim. So I think the question to focus on that was the, how are these kids doing with school reentry, and what are you experiencing new barriers that you maybe weren't before for some of our patients?
Yes, absolutely. I think that's huge. Lots of kids who had some level of anxiety, social anxiety, school avoidance beforehand, to go that long, in an avoidance situation. We all know, from a psychological perspective, that was a lot of avoidance, which then fed a lot more anxiety. So we're seeing a lot of that as well. And as Kara said, for our chronic pain kids, for a while, it was like, oh, look, now everyone's living my life. And then, to then try to go back from that has also been a challenge. So we have to be creative about that. I'm actually working, as Jen knows, as somewhat of a collaborator, working on a program to use virtual reality to help reintroduce kids to a school situation, so that we can really do an exposure kind of treatment to gradually help them decrease the anxiety about returning to the school situation. So I think we have to kind of pull out all the stops on this question.
Great. So, I think this discussion has been great. We're all, a community of trying to learn and trying to take care of these kids as best we can. And, it's nice to know there's so many people out there who are having similar experiences. And I like to use these events to really, be supportive of each other. So certainly we've had some great, we have some great experts who are on our panel today. I'm sure if folks wanted to reach out to them via email, we can, if you guys don't mind, we'll provide your email addresses to the panel. So if anybody has any follow-up questions, I'd really appreciate, I'm sure they'd be happy to answer your questions in the future. And maybe there's opportunities to do some collaboration around this as we move forward, or at least just utilize this forum or other forums like the Pain Listserv to continue these conversations going, because I think this is really important. But we really appreciate your presence today. Thank you very much, and hope you have a wonderful rest of your week. Take care.
Thank you.